Welcome, and thank you for standing by. At this time, all participants are in a listen-only mode. During the question and answer session, please press star 1. Today's conference is being recorded. If you have any objections, you may disconnect at this time. Now I'd like to turn the meeting over to Ashley Ghaffar-Day. Thank you. You may begin.
Thank you, Diane. Good afternoon. I'm Ashley Ghaffar-Day, and I'm representing the Clinician Outreach and Communication Activity, COCA, with the Emergency Risk Communications Branch at the Centers for Disease Control and Prevention. I am delighted to welcome you to today's COCA call, Zika in the ED, How Emergency Care Staff Can Take Action. You may participate in today's presentation by audio only, via webinar, or you may download the slides if you are unable to access the webinar. The PowerPoint slide set and the webinar link can be found on our COCA webpage at emergency.cdc.gov/COCA. For continuing education, free continuing education is offered for this COCA call. Instruction on how to earn continuing education will be provided at the end of the call. CDC, our planners, presenters, and their spouses partners, which wish to disclose they have no financial interest or other relationships with manufacturers of commercial products, suppliers of commercial services, or commercial supporters, with the exception of Dr. John Mark Hirschon. He is a consultant for Pfizer related to sickle cell disease. Planners have reviewed content to ensure there is no bias. This presentation will not include any discussion of the unlabeled use of a product or products under investigational use. At the end of the presentation, you will have the opportunity to ask presenters questions. On the phone, dialing star 1 will put you in the queue for questions. You may submit questions through the webinar system at any time during this presentation by selecting the Q&A tab at the top of the webinar screen and typing in your question. Questions are limited to clinicians who would like information related to Zika virus infection. For those who have media questions, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. If you are a patient, please refer your questions to your healthcare provider. At the conclusion of today's session, the participant will be able to outline the importance of screening protocols for Zika, review nursing assessment and clinical interventions as it relates to Zika, describe the process for reporting Zika cases, discuss patient education and discharge teaching for any people who may be at risk for, exposed to, or diagnosed with Zika. At this time, I would like to introduce our speakers. First, Dr. Satish Pillai will provide welcoming remarks. Commander Satish Krishna Pillai is the Deputy Incident Manager for CDC Zika Response since May 2016, where he helps oversee and coordinate a variety of epidemiologic, entomologic, and laboratory activities across the CDC Zika response. Dr. Pillai is an internal medicine and infectious disease expert who joined the CDC as an Epidemic Intelligence Service Officer in 2011. Following his tour as an EIS officer, he joined the Division of Preparedness and Emerging Infections in CDC's National Center for Emerging and Zoonotic Infectious Disease. As the Deputy Team Lead for the July 2014 Liberia Ebola Response Team, Commander Pillai helped develop the original incident management system for the Liberian Ministry of Health. He also was a course developer and instructor at FEMA's Center for Domestic Preparedness in Anniston, Alabama, where healthcare workers were trained in life-saving personal protection and infection control before deploying to Ebola's treatment units in West Africa. In February and March of this year, he was the final incident manager for CDC Ebola response, shepherding the agency's transition from the Ebola emergency response to supporting the 3 West African countries affected by Ebola to better prepare for future disease outbreaks. Our first presenter is Dr. John Mark Hirschon. He is a professor in the Department of Emergency Medicine and in the Department of Epidemiology and Public Health at the University of Maryland School of Medicine. He is board certified in both emergency medicine and preventive medicine and has a doctorate degree in epidemiology and is also a member of the American College of Emergency Physicians Epidemic Experts Panel. Additionally, he co-authored a publication entitled Zika Virus, Clinical Information for Emergency Providers. Our second presenter is Nurse Monica Escalante-Colbuck. She is Senior Associate for the Institute of Quality, Safety, and Injury Prevention, Emergency Nurses Association, and has practiced emergency nursing for over a decade. She began her education at DePaul University, Chicago, where she received her bachelor's degree in political science. Her interest in health politics influenced her decision to pursue nursing, achieving her master's in nursing with an emphasis in public health. Her work at INA focuses on developing clinical resources to support various topics and issues of importance to emergency nurses. She is also a member of the American College of Emergency Physicians, ACEP, Epidemic Expert Panel, and has worked collaboratively with CDC and ACEP on previous practice resources such as the Identify, Isolate, Inform, Emergency Department Evaluation and Management for patients who present with possible Ebola virus disease triage algorithm. She has also worked with Johns Hopkins Medicine, Armstrong Institute for Patient Safety and Quality to develop Ebola training module for nurses, physicians, and healthcare workers. She continues to work as an emergency nurse using an evidence-based approach to refining practice. At this time, please welcome Dr. Pillai.
Thank you, Ashley. Good afternoon. CDC's Zika emergency activation is complex, and nearly every part of the agency is supporting the response. Our number one priority is protecting pregnant women who, if infected during pregnancy, can pass Zika to their developing fetus. Zika virus infection during pregnancy is a cause of the devastating neurologic birth defect, microcephaly, as well as other severe birth defects. Our emergency response has brought together CDC scientists with expertise in arboviruses like Zika, reproductive health, birth defects and developmental disabilities, diagnostic testing, mosquito control, and travelers' health. These experts help monitor and report cases of Zika to help improve our understanding of how Zika is spreading and where it's spreading, provide guidance to travelers and Americans living in areas with current outbreaks, develop laboratory tests to diagnose Zika, provide technical assistance to states to help prepare and respond to Zika, including technical experts who understand methods used to control mosquitoes that can transmit Zika. We're conducting studies to learn more about the link between Zika and microcephaly and Zika and Guillain-Barré syndrome. And we've deployed CDC Emergency Response Teams, or CERTs, that include experts in Zika virus, pregnancy and birth defects, mosquito control, diagnostic testing, and risk communications to jurisdictions that have requested additional assistance in addressing the Zika outbreak. We learn more about Zika every day. For the latest guidance, I'd encourage you to visit cdc.gov/Zika and consult the What's New section, which also has a timeline indexing all of our Zika-related guidance and alerts. As clinicians, we all have an important role to play in helping inform the public about Zika and ensuring the health and safety of pregnant women and their babies. Given the significant interface that emergency department providers have with their communities and the breadth and volume of clinical care you provide, we value the opportunity to partner with the emergency medicine community in disseminating information regarding Zika and further strengthening collaborations between public health and clinical communities. As noted by Ashley, we have two speakers from the emergency department community today, Dr. John Mark Hirschhorn and Ms. Monica Colbuck. At this point, I would like to thank you again for participating, and we'll turn the line over to Dr. Hirschhorn. Thank you very much.
Thank you, Dr. Pillai. I appreciate this opportunity to discuss the important topic of Zika with my colleagues. I'm going to go ahead and get started on this. It's important from an overall perspective to understand that there are many mosquito-borne viruses, and some are more deadly and concerning than others. Today, we're going to focus on Zika. Okay? Zika is a virus that has really dramatically come to our attention over the past year, though it was initially identified in the 40s. However, before we get too focused on Zika specifically, let's make sure we've got our terms correctly. So when we talk about an arbovirus, that's an arthropod-borne virus, such as, and arthropods are mosquitoes, ticks, and sandflies. So it's really, when we say arbovirus, it's the mechanism of transmission we're looking at. And there are a number of different arbovirus families, though the one that we're looking at most is the flavivirus family, which are single-stranded RNA viruses. Arboviruses, as said, are transmitted by arthropods. In this instance, we're talking about mosquito-borne. And though they can have rare person-to-person transmission, such as from blood-borne, so transfusion or sharing of needles, organ transplantation, breastfeeding, intrauterine, and sexual transmission. And we've seen many of these transmission patterns occur with Zika. And of the major arbovirus viral families, the one that we're looking at really at this point is the flavivirus family, which includes dengue, West Nile, yellow fever, and Zika. So you can see that this is a major family when it comes to diseases among men and women. So let's talk a little bit about Zika virus specifically. So as I said, it's a flavivirus. It's mosquito-borne, and the two main vectors that we see are the Aedes aegypti and the Aedes albopictus. And again, the Aedes aegypti is probably the main one that we know of, but we know that it is transmissible by both of these. Its primary amplifying host, so the main host that you see it kind of grow in, are humans and primates. Its distribution is primarily tropical around the world. Mostly in Africa is where it started, but we see it now a great deal in South and Central America, as well as in parts of the Pacific. In the U.S., in the continental U.S., currently, it's only seen in a small area around Miami, Florida, so down in Florida. Though if you look at other places, such as Puerto Rico, there's a huge amount of Zika virus going on there. However, unfortunately, if you take a look at something like the history of West Nile virus, the likelihood of spread of Zika throughout the U.S., despite best efforts, is there, and it's something that we need to be aware of and something the CDC is actively trying to prevent. Unfortunately, there is no vaccine for Zika at this time, though there are efforts to develop vaccines. Of the four major viruses I mentioned previously, Zika, West Nile, dengue, and yellow fever, there is a yellow fever virus, so there's some hope that over time we'll be able to get a Zika virus, but at this point there is not one. And essentially you treat Zika symptomatically. So for individuals who have the disease, it's mostly a symptomatic treatment. So who's at risk? Folks that are at risk, as I said, are folks that go to Central and South America, and including the Caribbean, some parts of Oceania and the Pacific Islands. Now, we could list a long list of countries and regions. My recommendation is that if you're thinking of traveling to one of these areas, go to the CDC website. They keep an updated list in terms of being able to know where the active countries are for Zika virus. As I said previously, Puerto Rico right now is very active, and there are some localized areas around Miami. So those are in terms of travelers. Now, for other people, if you've got a partner that's been infected with Zika or has potentially traveled to one of these areas, then you're at risk for transmission primarily from sexual contact, unprotected sexual contact. So those are the individuals at risk. What does Zika look like as a clinical disease? Well, for the vast majority, probably 80%, most individuals with Zika are asymptomatic. They don't have anything, or they have a very mild infection. If they do have something, which are a maculopapular rash, usually pruritic, low-grade or fever around 38.5, aches, myalgias, arthralgias, they'll have a non-purulent conjunctivitis, they'll have a little bit of conjunctival hyperemia, so a little red eyes, headache, achy all over, maybe a little swelling around the joints, and so it's really very much a mild type of symptomatology. Now, there are folks that will get serious complications. They're relatively rare, so they can get Guillain-Barré. And if you see someone with Guillain-Barré, then you're going to treat them for Guillain-Barré. There's not anything different simply because they're Zika or not Zika. And as mentioned earlier, the individuals who are really at risk are congenital infections. So pregnant women infected with Zika are at risk for their infants are at risk for serious congenital malformations such as microcephaly, and there are other pregnancy-related complications as well, such as miscarriage. But from an emergency department perspective, this is really not the area that we're going to be, in general, be treating. You're going to come in and you're going to treat the patient for what they have. If mild and viral infection, if they're having a miscarriage, you treat them for what they're presenting with. So from a clinical perspective, at least in acute setting, there's not much we're going to do. How do you diagnose Zika? You diagnose it primarily based on travel history and symptoms. There is testing for Zika, and I'll show in a second a slide for testing for someone who's pregnant with potential Zika, but the answer is it's a complicated process. There are no currently approved commercial tests available. There are some tests that the FDA has authorized for use under an emergency use authorization. What I would recommend is that, again, you visit the CDC website to understand what the most updated Zika testing recommendations are. And here, so, if you have someone who comes in who's pregnant, as you can see, it's a complicated testing algorithm, in part because there's a lot of cross-reactivity for some of these tests with other flavivirus. So is it dengue or is it Zika? So depending on the type of testing you have and what's available to you, again, check the CDC website for current updates. Communicate with your hospital infection control individuals so you understand what the expectations are at your institution, and make sure that there's a communication between your department and the local health department to understand if you're going to test someone, where you send the specimens, how they're going to be processed, those type of questions. Again, while there's some general guidelines and the CDC has some specific guidelines for testing for pregnant women, it really is going to be a local effort depending on where you are, the symptomatology, the person's past travel history. So again, this is going to have to be tailored to your individual department. And what is the treatment? Well, right now the treatment is rest, fluids, acetaminophen. You don't want to stay away, as with a lot of the other flaviviruses. You really don't want to go towards aspirin and non-steroidal. So really it's just symptomatic treatment. Now, what do you want to tell a concerned patient? Well, in general, you can reassure them that it's a mild disease and that the vast majority of people are not going to get significant complications related to that. Tell them that if they've traveled, that look at their risk profile. If they haven't traveled or haven't been in contact with someone who has traveled to an endemic area with mosquitoes and Zika, then they're not likely to have it. If they are having sex with someone who has traveled there, or they've traveled there and having sex with someone, then they need to be aware of that they should take preventive measures. And we'll talk about those in a moment. So in general, the vast majority of people, it's going to be an issue of reassurance and symptomatic treatment. Now, if someone is pregnant and they're concerned about having gotten Zika, what do you tell them? And I would recommend that you send them to mothertobaby.org. This is a site that you can get through the CDC, and they have both English and Spanish individuals available to talk to people to give them advice and guidance and potentially help them in terms of testing schema. In the emergency department, you're going to treat the acute patient. The key here is to be able to make sure that you've got the appropriate mechanisms for screening, as Monica will tell in a little bit, but also to make sure that you've got appropriate referral mechanisms available so that the individuals can get the care they need and the reassurance they potentially need as well. So for a traveler going to an endemic area, it's really prevention against getting bitten. So, in general, wear long pants, long sleeve shirts, use appropriate mosquito repellents, stay in places with screening or air conditioning if possible. And really, recommendation at this point is that pregnant women should not, or individuals who want to get pregnant, should avoid travel to Zika endemic areas. From a sexual partner perspective, it really abstain from sex or use a barrier method for at least 8 weeks after illness onset if a female partner is likely to have Zika, And current recommendations are 6 months, the barrier method or abstention after illness if a male partner is likely to have Zika. And again, these are things that are, there's a lot of active research in this area because we're still learning about Zika. So these recommendations may change as our knowledge and experience and the research related to Zika expands. So kind of in conclusion of my part, Zika is not contagious in the way that Ebola was. It's not lethal, but it appears to strike in an especially cruel way, depressing brain growth in babies born to infected mothers. And like so many other pathogens that preceded it, the Zika virus has seemingly whirled out of nowhere, reinforcing how difficult it is to predict confidently which ones will go rogue. So the importance here is awareness, reassurance for patients, and appropriate follow-up. With that, I'm going to say thank you for your attention. And in the emergency department, we work as a team. So it's my pleasure to introduce, to transition to my partner on this talk, Monica Escalante-Colbuck.
Thank you, Dr. Hirschon, and good afternoon, everyone. I'm grateful for the opportunity to talk about a concern to all emergency care providers. I want to first start by talking about screening. As an emergency nurse, we do a lot of screening, and we may not even know it. We do it so often, it's almost second nature to us. With Zika, identifying emergency care patients who are at risk for Zika is one of the first steps we can take to prevent further exposures. Recognizing potential patients and understanding the clinical presentations of Zika virus can really help us in early detection as well as early response. In order to detect potential patients who are both at risk for or might have been exposed to Zika virus, clinicians must be asking the right questions. And how do we do that? Really, we can do that by universally screening everyone that presents to the emergency care setting. In healthcare, we use screening interventions to help us identify diseases early, enable early intervention and treatment in order to reduce the chance of disease and mortality. Screening for Zika virus will help us to identify exposed patients early, allowing earlier intervention and treatment, which in turn really assists in reducing the chance of further disease transmission. Knowing earlier that someone is at risk for or might have been exposed to Zika virus enables healthcare providers to intervene earlier, begin testing and treatment sooner, and helps clinicians target patient education and disease information that particular individual needs. Also, identifying Zika early through screening can help public health authorities track exposures, conduct follow-up, and determine eligibility for the U.S. Zika Pregnancy Registry. So we're going to do a poll, and I want to see if those of you who have access to the poll, who are on the webinar here, I want to know, of those of you who are currently working in emergency department or an urgent care setting, are you currently screening all patients for Zika virus? So I'll give you about 15 seconds or so to go ahead and complete the poll. Okay, I'm going to close the poll, and then let's see what our results are. Okay, so, well, that's about where I thought we would be at. So looking at these numbers up here on the screen, it seems about half of us are actually screening all patients for potential Zika virus. All right. So when we talk about who should be screened for Zika virus, we have to remember that many people infected with Zika virus won't even have symptoms or will only have mild symptoms, if that. As Dr. Hirschon mentioned earlier, the most common symptoms of Zika are fever, rash, joint pain, and conjunctivitis. Because these symptoms are so similar to the common cold or flu or even other diseases, it's important to assess every patient for potential exposure to Zika virus that presents to an emergency care setting. Most importantly, healthcare providers should be assessing all pregnant women for possible exposure and evaluate for signs and symptoms of Zika virus disease at every clinical encounter. Clinicians will find the updated interim pregnancy guidance testing algorithm that Dr. Hirschon talked about located on the CDC's website, which is very useful for this assessment. While some may tend to only think about pregnant women being impacted, we have to remember that Zika can be passed through sexual contact, even if the infected person does not have symptoms at the time or may not even know they are infected. Therefore, screening for potential exposure is necessary for all individuals. The first question asked by most triage nurses is, what brings you in today? It's a typical question. We ask it all the time. And whether it's abdominal pain, finger injury, or, say, headache, travel history should be included in the primary assessment. This can easily be done by starting with a very simple but important question. Have you had any recent travel? Or has anyone close to you recently traveled? But not all patients presenting to an emergency care setting are going to know what areas are impacted by Zika. This type of open-ended question, have you had any recent travel? Has anybody recently close to you traveled? This type of open-ended question really puts the burden upon the clinician to know which areas are affected by Zika. And as emergency nurses and emergency care providers, we should also be prompting and asking our EMS providers as we receive radio calls to screen patients they bring in to us at the emergency department. Internal and external hospital websites should include a link to the CDC's Zika website to ensure that all staff have easy access to the most up-to-date guidance, including current areas affected and other training and clinical resources. So because not all patients are going to know, these links and resources are really going to help you determine which areas are impacted and whether or not that patient needs to be further evaluated. Having a map or something similar to this with tips for triage that is updated can help to remind clinicians to rescreen everybody. So this map, you can see up here, it's kind of triggering questions, identify exposure history and patients at risk. Now the map is rather general. As you can see, it's only pointing to the Americas, but you're going to want something more updated that shows Miami and Puerto Rico as well. So it's important to make sure that everyone has easy access to online resources. At ENA, we developed a quick fact sheet for emergency nurses with common questions and answers. We recommend that emergency departments post this or something similar with quick information where it can be easily accessed as a reminder to screen all patients. So once we've assessed whether an individual has been exposed by asking travel and exposure history questions, then our next step is to identify the signs and symptoms, which are listed here and which Dr. Hirschon mentioned. After we've determined if there is a potential risk for Zika, then we're going to have to figure out what sort of isolation precautions are needed based on the symptoms. For Zika virus, standard precautions should be implemented. Isolating or moving the patient in a private room would be an ideal situation, not only for their privacy, but also to limit distractions so that appropriate patient education can be provided to the patient and their family. A question that often presents is, as an ED nurse, can I get Zika for my patient if they have it? And what we have to remember is that body fluids, including blood, vaginal secretions, and semen, have been implicated in transmission of Zika virus. So it's really important for us to practice correct standard precautions. Occupational exposure that requires evaluation includes percutaneous exposure like a needle stick or other sharp injury, or exposure of any non-intact skin or mucous membrane with blood, body fluids, secretions, and excretions of the suspected or confirmed patient. Before I jump over to the process for informing and reporting cases, I want to first talk a little bit about clinical interventions from a nursing perspective. Dr. Hirschon mentioned a lot of these interventions that we would be doing, but it's important to be aware that people with Zika virus infection can be asymptomatic or mildly symptomatic, and therefore we should consider Zika virus disease in our differential diagnosis for patients with appropriate risk factors. Since there are no antiviral treatments for Zika, we're going to really focus on supportive care, and that should be given for any symptoms such as, rest, antipyretics, pain management for any pain that they have, and possibly fluids. Clinicians should not be administering aspirin or other non-steroidal anti-inflammatory drugs or NSAIDs until dengue can be ruled out to reduce the risk of bleeding, as Dr. Hirschon had mentioned. Nursing interventions should also include a thorough travel assessment. It should also include patient education and comfort measures, including safety and pain management. We should also, as clinicians, make every effort to use the available resources that we have and consider even using bereavement support for the patient and their family. Also, I would consider using a chaplain or mental health liaison, maybe even a social worker or other ancillary staff experienced in providing psychosocial support. If a Zika infection is suspected, there will most likely be a blood test to detect the virus. CDC labs will analyze the specimen. Patients should be given step-by-step instructions on what to expect to help with any questions they may have throughout the process. Most patients presenting to the ED with a potential Zika infection will be stable and will only require referral services with patient teaching. In some cases, an ultrasound may be conducted, and to help support clinicians, the Zika pregnancy hotline can be accessed for any questions. Zika virus disease is a nationally notifiable condition. Healthcare providers should report suspected Zika virus disease cases to their state, local, or territorial health departments to facilitate diagnosis and mitigate risk of local transmission. Each facility or emergency care setting is different and will have different policies and procedures for reporting cases of Zika, so it's really important to follow your institution's policies and procedures. Designated healthcare staff should report suspected cases to state or local health departments to facilitate diagnosis. So we have to work collaboratively with your physician and infection control prevention group to decide on who's going to be the one to report the case. Diagnostic testing will be completed by state, local, or territorial health departments and will report laboratory confirmed and probable cases to the CDC. So what emergency care providers, hang on one second. So what emergency care providers will be doing is providing patient education and discharge teaching. Patient education should be targeted to the individual's needs and diagnosis. It's difficult to predict, what sort of patient is going to be presenting to the ED, so it's better to be prepared for any potential scenario. The most important thing to remember is that the information we do provide must be the most up-to-date information from reputable sources. Clinicians don't have to reinvent the wheel. However, the CDC has developed a plethora of resources, both for healthcare providers and information directed for patients. Most patients presenting to an emergency department benefit from Zika basic facts, including transmission and information on how to protect themselves. Depending on the area in which you live, you may want to provide more information on mosquito control and prevention measures. Pregnant patients or patients who are trying to get pregnant should be provided with travel advisory information and should always be referred to their OB/GYN for additional concerns. Additional patient teaching. So patients who have been tested can be provided with step-by-step infographics from the CDC on what happens when someone is tested. Those suspected of being infected must be cautioned about mosquito exposure during the first week of illness to prevent further transmission. Men who have traveled from an area with circulating Zika virus and who have a pregnant partner should be instructed to abstain from sexual intercourse or use condoms consistently for the remainder of the pregnancy. Women planning to become pregnant and who have traveled to a Zika-infected area should be instructed to wait at least 8 weeks after the last possible exposure. As for men, as Dr. Hirshon talked about a little bit, they should be instructed to wait at least 6 months after symptoms start or from the last possible exposure. Pregnant women who test positive should be referred to maternal fetal medicine specialists for serial fetal ultrasounds and possible fetal testing. More than likely, the patients will have many questions, which is, understandable, especially for those who are pregnant and are suspected to have a Zika virus. If families would like to speak to somebody about a possible Zika virus infection or diagnosis during pregnancy and what the risks are to the baby, it is advisable to have them contact mother to baby for more information and supportive care. As emergency providers, our focus is really on treating the immediate symptoms. We also are accustomed to providing psychosocial support and ensuring we are giving appropriate patient education, discharge information, and referrals. Keep in mind, though, that in certain circumstances in the emergency department, we may be the ones responsible for coordinating care with multidisciplinary teams, including home care. Therefore, it's really important to understand your individual hospital policies and procedures, including who to contact to help facilitate testing and diagnosis, as well as follow-up care. When you have an opportunity, please take time to visit the CDC's website for valuable information, including clinical guidance. Thank you for participating on this call. And I'm going to turn it over to the moderator.
Hi, this is Ashley again. Thank you, presenters, for providing our COCA audience with a wealth of information. We will now open up the lines for the question and answer session. Joining us for the question and answer session are Dr. Preeta Cuddy, a CDC Healthcare Infection Control subject matter expert, and Dr. Athena Curtis, a subject matter expert from CDC's Pregnancy and Birth Effects Task Force. Questions are limited to clinicians who would like information related to Zika virus infection. For those who have media questions, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. If you are a patient, please refer your questions to your healthcare provider. When asking a question, please state your organization, and also remember you can submit questions through the webinar system as well. Actually, we have a question here now. The question is there a recommendation for CDC or current president to do universal screening in the ED? Presenters, are you able to respond?
Yeah, so what I would say is that Zika is a reportable disease. But I do not believe that it's required to do universal screening. And to be honest, I'm not sure that would make sense in many of the areas, particularly in the northern part of the continental United States. I'd have to defer to my CDC colleagues, but to my understanding, while it is a reportable disease, screening is not currently required.
Yes, thank you. This is Dr. Curtis from the Pregnancy and Birth Effects Task Force. That is correct. The current recommendation is for all pregnant women who have been exposed either through travel or through sexual exposure. Even if asymptomatic, the recommendation is for all pregnant women who had exposure to be screened, to be tested, but not universal screening.
Thank you both. Operators, can you go ahead and open the line for questions, please?
Thank you. As stated, if you would like to ask a question, please press *1. You'll be prompted to record your name. To withdraw your request, please press *2. Dr. Warner Hudson, your line is now open, and please state your organization.
Hi, this is Warner Hudson from UCLA. I'm the Medical Director for Occupational Employee Health for the health system in the campus. And just really a comment more than a question. We have a lot of travelers for work and research who go to Zika areas and come back. And we also do live Zika work in our labs. So we have started doing testing for those with exposures. We do a commercial test. It's, I think, a ViraCore test, blood and urine PCR early, and IgG, IgM later after exposure or symptoms. And Our lab is doing about 10 of these a week, has had some positives. Of course, those would be confirmed with the Public Health Department CDC-type test. And I'm just wondering if you've begun to think through the algorithms for these occupational health exposures, which certainly do show up in the emergency departments and urgent care when we are closed, or people don't happen to come to us, they go to the emergency room. Thanks.
Good afternoon. My name is Preeta. I belong to the Healthcare Infection Control part of Zika response. Yes, we certainly are looking into that as well. We hope to have some guidance soon. But in the absence of, occupational exposure, they should follow the guidance that has been provided so far, and take the necessary precautions. But thank you for raising that question. We appreciate it.
Sure, thank you.
Amy Derman, please state your organization. Your line is open.
Hi, this is Amy Behrman from the University of Pennsylvania, and I also would like to make a comment and ask a question about occupational exposure risk. This not so much for travelers and laboratory researchers, but for healthcare workers. As your presentation pointed out, the risk of occupational exposure in a clinical setting is low, but I think we all know that the anxiety that will occur is very high when there's occupational exposure, particularly in settings where a very large proportion of the healthcare workers are women of childbearing age, which is the case for most of us. My question is, are there any circumstances at this time where you recommend testing source patients in an occupational exposure needle stick type situation if there is no preceding clinical suspicion for Zika in the source patient?
It's John Mark Hirschon, and I can't speak for the CDC. I'm not aware of anything like that. But what I would say is, you have to take a look at the risk profile if you're considering testing for something. So if someone has no travel history, no symptomatology, nothing to make you think of it, I think that would be a bit of at least from a clinical perspective, a bit of an overreach. I do recognize that there's a significant anxiety component to it. And that's something that an individual healthcare provider who has had a needle stick will have to address, and perhaps something that they can follow up with the occupational health of their institution. But I think from a clinical perspective, it would not make sense to test someone to do additional tests on a source subject if there's no clinical indication for that.
I don't know if I'm still live on the line, but that actually makes complete sense because the positive predictive value in that setting would be so low. I think it does, support the concept that we should be making sure that our institutions are at least double-checking the screening questions with source patients, even if the institution is not doing universal screening.
Yeah, and this is Preeta again from the infection control side. As was mentioned earlier, we certainly, unless there is no risk factor, we don't recommend testing if they do have certain risk factors that have been either identified or through your questionnaires, or we don't really recommend the testing part of it. We haven't seen any data as yet, but however, based on new information that may come, and that was mentioned during the presentation, there's always new information coming every day. We'll certainly keep everyone posted and up to date.
Thank you.
You guys are asking great questions, and they're very thoughtful and really kind of are from a clinical perspective, I think part of the cutting edge of trying to address this in the emergency department.
Operator,
Jamie DeFrancisco from Palmetto General Hospital. Hello?
Yes, we hear you.
Yes, hi, good afternoon. I wanted to know, what is the recommendation if a mom tested positive once the baby is born? What is the recommendation?
This is Athena Curtis again from CDC, the Pregnancy and Birth Defects Task Force. There is guidance that CDC has issued on the evaluation and care of the infants of mothers with congenital exposure, and we can send that link if you would like. It really depends on whether the infant has symptoms present at birth and or not. And we do essentially recommend that the infant be tested in circumstances where the mother has either laboratory evidence of Zika exposure or where there is strong suspicion based on epidemiologic links, and the infant has abnormalities that could be consistent with Zika. And we do recommend that the baby be tested in the first 2 days of life, if possible, or as soon as possible thereafter. And the recommended testing includes serum and urine, for PCR and for IgM. And there's also a number of other evaluations the infant needs to have, including, the head circumference, careful, close monitoring of the infant growth, an eye exam and hearing test, and there's a long list of other things that need to be considered, along with congenital Zika infection. We can forward the updated guidance if you would like.
Yes, please. That will be great. But do we have to test the infant, even if, I know we have to do a very thorough, assessment on the baby. If the baby shows no sign or symptoms of Zika, do we still have to go ahead and is it recommended to do the serum and the urine testing?
We do, if the baby is normal, but the mother has laboratory evidence of Zika infection, that really might depend on how, the discussion between the healthcare provider and the parents and how comfortable they feel. We do have some emerging information that infants may appear normal at birth and may have normal head circumference, but they may start to develop abnormalities later on. And we have seen that happen in Brazil and in other settings where the head circumference may fall off the percentiles as the infant grows in the first few months of life. And there are also indications that the infant may have other abnormalities that are very subtle, such as isolated hearing loss, perhaps. So we do want to capture all these infants, and we would err on the side of testing all infants where the mother had a convincing case of Zika infection during pregnancy.
Okay. And one more question, I'm sorry. How long is the recommendation to follow with these cases for like the baby? For example, if the baby is negative, comes back negative, and there's no sign and symptoms, how long is it recommended that the parents continue to follow up?
Well, if the infant, has negative testing and appears completely normal in the initial evaluation, so that would include a hearing screen and an eye exam, then, the baby can have just the routine, infant care. And the pediatrician and the parents, of course, would closely monitor the growth and development of the baby. And then we would feel comfortable having, this routine care for the baby.
Okay, perfect. Okay, thank you.
Sure.
Operator, any more questions?
Your line is open.
Hi, this is Pam Alexander, infection preventionist from the West Palm Beach VA, and my question isn't directly about ER, but I do have a question about Guillain-Barré. To have a patient who presents with Guillain-Barré with just living in an area where there are localized, albeit low transmission, have been local transmissions. Do you think it appropriate to test them just for epidemiologic reasons?
From a clinical and epidemiological perspective, I think it would be reasonable to test them. And I would probably go a little further in that if you have someone, especially if they had recent symptomatology that makes you concerned, that you have to consider that they're at risk for, transmission. So I would probably, at least start from isolation if you've got the appropriate epidemiological kind of background. So, someone who's traveled there or you're in an area where there's transmission, then I would think it appropriate to test them, because Guillain-Barré is still a relatively unusual condition, and especially if had recent, viral type of infection. So.
It's really not. It's not. The index patient that we were discussing here did not have any clinical presentation that had enough specificity for the health department to want to test him, but there was some unknown illness, and anyway, I just wondered if you thought, even in the absence of symptoms, would you still feel it prudent just to test them?
If I'm concerned from an epidemiological perspective, so if I think that they've got risk because of recent travel, sexual contact, or endemic within the area, then I would consider that as part of my panel. If I had any concerns or wasn't sure, then I would check with my infectious disease colleagues at my institution.
Yeah, thank you very much.
I show no further questions.
Okay, this is Ashley. I have something that came in through the question and answering webinar option. We have Julia Schaffner. She says, thank you for the presentation. I think I might have heard one of the speakers mention that only health department labs and CDC can test for Zika, but just want to clarify that there is some commercial lab testing for Zika virus currently. Both LabCorp and Quest offer RT-PCR and MAC-ELISA IgM Zika tests.
And it's true, there are no formally commercially approved tests, but there are FDA-approved emergency use tests available, so some labs will be using those tests. They're not, again, they're approved under kind of an emergency use process. So from a recording or from a documentation perspective, I think the reporting process will go through the local health departments.
Thank you. Well, at this time, Dr. Satish Pillai will provide closing remarks, and I will follow with instructions for continuing education.
Thank you, Ashley, and thank you to our speakers today. Today we've learned the role of emergency departments and how they can assist in the current response to the Zika outbreak that we've seen. We hope today's presentations will assist you as you manage patients in your busy practices. As emergency providers, you have significant interactions with members of your community and can have a role to play in screening for Zika exposures, as well as diagnosing and reporting Zika. Screening for relevant travel or sexual exposure history and understanding the constellation of potential symptoms can help inform decisions regarding the role of testing and the type of testing that may be appropriate. And you can help provide the appropriate prevention strategies to reduce the risk of mosquito-borne transmission and sexual transmission. All of these activities are of particular importance for our most vulnerable population of pregnant women. So once again, thank you for participating, and please do visit the CDC website if you have any questions regarding what's new and for CDC's latest guidelines. Thank you.
The recording of this call and the transcript will be posted to the COCA website at emergency.cdc.gov/COCA within the next few days. All continuing education for COCA calls are issued online through the TCO Online, the CDC Training and Continuing Education Online system at www.cdc.gov/TCE-online. Those who participated in today's COCA call and would like to receive continuing education should complete the online evaluation by December 5th, 2016, and use the course code WC2286. Those who will review the call and on demand and would like to receive continuing education should complete the online evaluation between December 6th, 2016 and December 6th, 2018, should use course code WD2286. To receive information on upcoming COCA calls, subscribe to COCA by going to the COCA webpage at emergency.cdc.gov/COCA. COCA and clicking on the Join the COCA mailing list link. Also, CDC launched a Facebook page for clinicians. Like our Facebook page at facebook.com/CDC Clinician Outreach and Communication Activity to stay connected to the latest news from COCA. Thank you again for being part of today's COCA call. Have a great day.
This concludes today's conference call. Thank you for